I once had a doctor recommend that I cut out caffeine for a medical reason. I tried it. I lasted 3 days. It's called non-adherence. A patient who's not following the recommended medical treatment for a specific illness or diagnosis. Now, there's a lot of reasons why patients are non-adherent to the recommended medical treatment and plan of care. I was one of those patients. I love my morning coffee, and it just wasn't something that was worth it to me to give up for the proposed benefit that it might have. So today we're going to be talking about non-adherence and what that means in nursing. So we're going to be just in your Giddens text for this topic. We're going to be in Giddens chapter 6. Now you're going to be wanting to complete your study guide on adherence as we go through this and be able to meet these objectives, being able to define and describe in your own words the concept of adherence, and then recognizing the levels of adherence, because you can be completely non-adherent to perfectly adherent to somewhere in the middle with patients and their medical adherence. And then identify some situation or factors that affect adherence, because let's be honest, our patients aren't always perfectly adherent to the recommended plan of care. So we want to be sensitive to why and help patients overcome that if possible, and also recognize that we need to adjust our plan of care to meet our patients' needs as well. Let's be real, I am not getting rid of coffee. So if my doctor wants me to cut back on caffeine, they're going to have to suggest some other options, because that is not something that I'm willing to adhere to. So let's go ahead and define and describe the concept of adherence. This is going to go on your study guide, your concept study guide. So there's multiple different definitions of adherence, but basically the gist of it is to what extent a patient follows the instructions and recommendations that they're given as part of their treatment plan for whatever they're seeking healthcare for. Now, we used to describe adherence as compliance, and oftentimes you'll see this still especially in like documentation that staff do at a hospital. They'll say the patient is non-compliant with their blood pressure medicine. And compliance is a descriptor of patient's obedience to prescribed treatments. And I think that there's been this transition away from that kind of word, from compliance, meaning obedience, to adherence, meaning how well someone follows it. And the reason we've changed that is we want to provide patient-centered care. And that means adapting to their cultural desires and their health beliefs and their own lifestyle choices, and making sure that our recommendations are aligning with what they're actually going to do, and making sure that they are the drivers of their care. We're just helping them. It's their life, and they're in the driver's seat, and we are supporting them. Where compliance means we're in the driver's seat and you have to follow what we're doing because what we know is best. And so there's just been this shift and change in terminology from things like compliance to adherence. And one way that I've demonstrated this in my own charting is I used to write patient refused medication. If they were in the emergency room and they came in and we offered them medicine, I'd say I charted in my note, patient refused medication, patient refused blood draw. And I've switched my terminology, even in my own charting, to saying patient declined blood draw, patient declined medication, because again, that puts them in the driver's seat and we are supporting what they want. So our patients can be on a whole spectrum in terms of the scope of adherence. They can be at total adherence, which is quite frankly quite hard to do depending on how complicated your medical diagnosis and treatment plan is, but they can be on the spectrum of total adherence to partial adherence, not intentional, to partial adherence intentional, where they're intentionally not doing something, not adhering, or just non-adherence, completely not doing what they're supposed to. If you remember back to the ethics lecture, we talked about the 28-year-old diabetic who came in every week multiple times because he wasn't taking his medications. And that was just an example of complete non-adherence. It was intentional, and because of his complete non-adherence, he was having major medical crises multiple times a week that required ambulance rides and trips to the ICU. Where in my case, my cardiologist wanted me to cut back on some caffeine, and he wanted me to cut out caffeine And I made a partial adherence, an intentional choice to continue to have some caffeine, but cut back on my dosage, so to speak. So we can run this whole scope of total adherence to non-adherence. My mom has some memory loss sometimes, some short-term memory. She's extremely bright, she's an incredible person, completely independent. But once in a while, she has some short-term memory lapses. And I found out recently that she was having partial adherence to her medications, but it was unintentional because she didn't have a good reminder to take her bedtime dose of her medication. And so it was just, she was forgetting. So it was a partial adherence that was non-intentional. So there are definitely consequences to non-adherence for a recommended treatment. And the consequences will, for non-adherence, fall into three areas, three categories. They can be patient-related, where the patient faces the consequence. So a patient who doesn't take their insulin and is diabetic is going to have high blood sugars, just like our friend who was non-compliant and non-adherent and coming to the ER for his blood sugars over 800 multiple times a week. So he faced those consequences. He felt terrible. He was fatigued and was poked multiple times all the time going into the ICU and the ER. So that's patient related. It can be health professional related, where the health professionals who are giving advice and continue to see patients come back and back and back can kind of get burned out on that, or even ambivalent, like, fine, do whatever you want with your life, but I'm so sick of caring for you. And so there's certainly consequences to us as healthcare workers. Just the burnout and the frustration we can see with non-adherent patients. And then there's the relation of the consequence to the healthcare system as a whole. And think about the healthcare dollars that are being funneled into some non-adherent patients. So that patient who I had, the 28-year-old diabetic who wouldn't ever take his insulin, refused to go to a nursing home or declined to go to a nursing home, so where he could get his medication administered. That was a huge suck of healthcare dollars because all those multiple ambulance rides, ER visits, physician bills, pharmacy bills, and ICU stays. So there are consequences in a variety of different ways for non-adherence. So let's talk more specifically about those consequences for each of those three areas. Now for consequences for patient-related non-adherence, it can increase their mortality and morbidity rates. Sicker and they die sooner. It can cause conflict between the patient and the healthcare provider who's offering advice and recommendations. It can cause attributional uncertainty, meaning we don't know how the patient's going to do if they're not following the treatment plan or if they're not following it fully. We just don't know kind of how to guarantee what their health is going to be like. It can certainly be a point of embarrassment for patients, especially if the non-adherence is unintentional. And there can be changes in the quality of life because what the recommendations that the medical professionals provide are based on evidence and science on what's the best practices for a patient as a whole in generalities. And so not following that can certainly change a person's quality of life. Watching our patients not comply or be non-adherent with recommendations in treatment can certainly burn on us as healthcare professionals. It can make us feel ambivalent, like, fine, whatever, I don't really care. We can also misinterpret what their intentions are. Sometimes we can assume that they are non-adhering intentionally, where it could be an unintentional consequence. We can avoid it and just like not want to engage with the patient or not want to give advice because we just don't feel like they're going to follow it. And then we can also lose a lack of empathy. And so all of those things can impact us as healthcare workers. And it's important to keep our own emotions in check so that we are continuing to provide patient-centered care. And finally, like I said, on the healthcare system as a whole, it can increase the use of healthcare services and certainly increase the cost as well. So the attributes and criteria that are involved with adherence are decisional conflict, meaning a healthcare provider, being unsure what advice to give and treatment recommendations to give to a patient because you either know or don't know if they're going to follow it. An example I can provide, when my husband worked at a different hospital, they had a physician who would come in, and we had a lot of heroin users at the hospital, and they would be admitted for respiratory illnesses. And I'm not joking. There was a patient who came in, and one of the physicians said, and he was there for asthma, and the guy was like, "Are you gonna quit doing heroin?" And the patient was like, "Heck no, I've been doing heroin for 40 years. I'm not gonna stop tomorrow." And the doctor said in front of my husband in the room, "Well, do you shoot it or do you snort it?" And the guy said, I snort it." And he said, "You know, if you're gonna keep snorting heroin, you are going to die, because this is going to make your asthma worse. It's going to exacerbate your asthma, and you will die. So if you are absolutely not going to stop doing heroin, then you should shoot it instead of snort it, because it might save your life and not impact your respiratory system." And so there, wow, you know, like that we're going to advise a patient to shoot heroin? Of course not. But that doctor was trying to make struck with this decisional conflict of, do I just tell the patient never to use heroin again, but I know he's going to? Or do I give advice based on what I know he's going to adhere to try to save this individual's life based on this person's specific situation? So there's an example of decisional conflict as it comes to adherence. We struggle with predictability. We don't know how patients are going to do if we don't know what kind of treatment regime they're following. We certainly bring our own personal experiences in this, and that helps guide as we address specific patient situations. There can be a power conflict with me and my provider. Like, no, I'm not giving up coffee. So what else do you have? Any other good ideas? Because that's not going to happen. And then there's agreement. Hopefully the patients and their healthcare providers are in agreement with the plan of care. Super important that we can come to like a middle ground, and that we align our plan of care with something that the patient is actually going to follow. So while I don't always ask you to really focus on the theoretical links, this theoretical link, the theory of planned behavior, really helps us to gauge whether a patient can make change and adhere to a specific treatment recommendation. And so there's 3 components that can help us predict whether a patient will adhere. The first is, what is their attitude toward the problem? So if we're telling a patient that they're diabetic, is that something they're concerned about? Is that something they're worried about and want to make change on? Or is it something that they don't really care about? So the patient that was 28 that would come in, he didn't care that his sugar was high. We could tell him all day that your sugars are high and you're going to die from this, and he just didn't care. And so he had this behavioral belief and attitude where he didn't care about the underlying problem. So we're not going to get very far if they don't. The second part, the subjective norms, is the motivation. Is your patient motivated to make a change? So are they concerned about the problem? That's the attitudes. And are they motivated to make a change? That's the subjective norms. And then finally is the perceived behavioral control. Do they have the confidence and even the ability to make that change? Whether it's they need the money in order to eat healthier foods, or they need access to healthcare. Do they have the control on how to actually make those change happen? And all of those 3 things link in to behavioral intention that hopefully can lead to behavioral change. But if your patient doesn't care about the problem, or they're not motivated to make the change, or they lack the means to make that change, we're not going to see adherence. And so you want to be assessing if they're concerned about the problem, if they're motivated to make change, and if they have the ability to make the changes that are being asked of them. And the health belief model is very similar, very much overlapping with the other model. So there's this perceived susceptibility. Do they really believe that they can suffer the risks and the side effects of whatever that illness is? Perceived severity, how bad do they think it could get? The perceived benefits of adhering to the recommended treatment plan, and then the perceived barriers, like, I'm not going to give up coffee, so that's just a barrier to me being able to do that. It's not happening, right? So again, it's this understanding of the patient's intrinsic motivation and gauging that so that we can give realistic expectations and education to our patients about adhering. So the 3 dimensions of adherence are compliance, how well they want to conform with the treatment that we are recommending. Persistence, do they keep it up? So I'll tell you, when my cardiologist asked me to cut out caffeine, I did it for 3 days. I had massive headaches and I was tired all the time and it was terrible. So I did not persist. I lasted 3 days without caffeine. And finally, concordance. Is your patient in agreement with the actual treatment plan? Now, certainly nursing is not working in a vacuum when we're talking about patient adherence. And so there's multiple different disciplines that are also at play here. Certainly nursing, but also mental health. Patients who are depressed are not going to be able to do a great job complying with their nutrition plan when they can't hardly get out of bed and don't want to think about eating healthy. So our mental health plays into that. Medicine, meaning doctors, also definitely recommend plans of treatment and have to align with what we're doing as nursing. And then pharmacy, do patients have access to medication? Can't tell you how many times patients would come into the emergency room with their blood pressure systolic over 200, risking a stroke, and they would say that they ran out of their blood pressure medication and couldn't afford anymore. Or a parent who would bring in their 8-year-old for wheezing, and it's the end of the month, their asthma inhaler for the kid ran out and they can't get a new one until the beginning of the month, and they don't have money for one. So certainly the pharmacy and medication access can certainly play into adherence as well. There are so many interrelated concepts when it comes to adherence. The beliefs from one's culture and what health beliefs they bring into their life certainly comes into it. Now, their functional ability, are they physically able to follow the treatment plan? Their developmental level, can they understand, and cognition, can they understand the treatment levels and treatment recommendations? What are the family dynamics? Do they have a caregiver in the home? Is the caregiver on board with the treatment plan? And what about their spiritual beliefs and how that impacts how they adhere or don't adhere, or what treatment they agree to or don't agree to based on their own beliefs, either from their culture or from their spiritual background. And so that's why we have been looking at things like culture and spirituality, because all of these things are definitely interrelated with how well our patients adhere to recommended treatment plans. And we need to be sensitive to that and aware that those things can impact adherence. Finally, the exemplars that your text offers for this chapter are medication taking behavior. So I take Synthroid for a low thyroid, and they recommend that you always take it first thing in the morning on an empty stomach. But my mornings seem different every day. Sometimes I wake up early, sometimes I sleep in, and oftentimes, I hit the ground running and go straight to work. And I found that I can't take my thyroid medicine in the morning because I forget. But I know that I take it right before bedtime every day, that when I brush my teeth, I take my thyroid pill, and I never forget it that way. So there's an example of my physician working with me to find a treatment plan that I could adhere to and have a good outcome from. Dietary modification. Who wants to be put on a diet? No one. I hated being taken off caffeine. You're not going to do it again. I'll never do that again. Diet and exercise are other ways that we ask patients to adhere to a specific treatment. And it's not always just for weight loss. It can be for a variety of things. And we'll be talking in 108 about nutrition and the different types of nutrition diets that our patients are put on for a wide variety of things. But these are the kinds of things, medications, diet, and exercise, that we ask our patients to adhere to. So adherence is really important for our patients in order for them to have wellness and experience true health. But sometimes the things that we ask our patients to do, like cut out caffeine, can also have detriments on their wellness in terms of their whole lifestyle. So we need to be sensitive to all the different things that our patients require, their health beliefs, their spiritual beliefs, their cultural background, their lifestyle choices, and make plans of care that align what we do with what the patient wants. And ultimately, it's about their motivation, their desire to seek wellness for them, and define what that means in their life. Remember, we are the advocates of our patients, and we are going to put them at the center of our care. That's it for adherence. Have a great day.